Dear doctors, welcome and thank you all for joining us today at our live webinar with Dr. Amos Yahav. My name is Amit and I'm the Director of Education at Augma. I will be the moderator for today's session. Please feel free to send me direct messages during the webinar if you need any assistance. Let me start by wishing you, from all of us at Augma, health, and we hope you are safe and well during these times we face. Today's webinar is the first in a series of webinars Augma is promoting these days. The webinar will be followed by a Q&A session and a few small announcements about upcoming webinars and more interesting news, so please stay tuned. During the webinar, we welcome you to send questions by clicking on the Q&A button at the lower part of your screen, and they will be answered by Dr. Yahav at the end of the session. And now, without further ado, I'd like to welcome Dr. Yahav, the inventor of biphasic calcium sulfate, CEO and founder of Augma Biomaterials, and the Thomas Edison Award for Innovation winner of 2019. Dr. Yahav, the virtual floor is yours.
Thank you very much, Amit, for your introduction. And thank you all for joining me and participating in this first webinar in our series of Augma Bond Cement Academy. Since I see that we are a few hundreds from different parts of the world, so I will start with good morning, good afternoon, and good evening, wherever you are. And I would like to wish you as well, let's pass this period as quick as possible with health, and let's hope that this will be a physical health, mental health, and not less important, an economical one. So I would like to start with my presentation, and the topic of my presentation is socket preservation and soft tissue rehabilitation in the posterior area of the oral cavity and also in the aesthetic zone. How we can treat it by using Augma bond cements. So let's hope that it's working. So the question is, there are two questions, why and how? And the why is divided into two. Why actually do we need to perform socket grafting? Because as we know, in the first 2 years after extraction, 30 until 60% of bone loss can be seen. And we can lose the width and the height. And if we don't perform the socket grafting in the time of extraction, actually, later on, we need to deal with much more complex cases of augmentation, which are also much more expensive, time-consuming, and also with different complications that might be associated with. The second question is, why there are so many general practitioners who do extraction, but they're reluctant to do socket grafting? Even so, there are many doctors who have experience in surgery, who do augmentation, and not each one of their cases after extraction, they do socket grafting. So those questions are answered by the reason how we perform traditional grafting in those days. So as we all know, we have different families. We can have the autograft, the holographed, the xenograft, and the synthetic material, which are many kinds of different material that behave differently, but most of them today come as granules or as putty in order to improve the handling. Normally, we need to use a membrane, and the outcome mostly is integration and not necessarily regeneration. So actually, if we take a call for histology, even after 6 months, probably we're going to find 80% of the graft himself and maybe 20% of the vital bone. But this is not the main reason, because it works. The main reason why we don't perform in each case augmentation procedure, in each case we don't do socket grafting and socket preservation, is because the traditional approach. We have some requirements that we are forced by those techniques. We need to do a tension-free flap, primary closure. We need to add some additive in order to improve the quality of the bone. We need to use membranes, and we deal sometimes with postoperative complication. Actually, when we look at it, it looks to us normal. That's how we used to do. But all of those are drawbacks, and I'm going to elaborate a little bit about it. What's wrong about tension-free? First, in order to gain tension-free, we must be more intrusive than actually is needed. We need to go with our flap upper. Then we need to dissect the periosteum or the connective tissue in order to release it. It requires some skillfulness in order to do it, some experience, but not just that. When we do tension-free, actually we are more invasive to the patient. Later on, he's coming with more pain, more swelling, and we connect the flap to the muscle, and any movement of the muscle can jeopardize the outcome. So if we can get rid of it, that will be fantastic. Primary closure, we know that if we don't gain a primary closure, actually it might get exposed, and if it will get exposed, it might get contaminated, we might lose soft tissue and hard tissue, and then we need to repair it, and sometimes we can end up with irreversible stage. Additive, of course, because if we have mostly integration and mostly is the graft himself, we want to improve the quality of the bone in order to enhance a little bit the healing. So, or we use autogenous bone graft and we mix it with our graft, or we use sometimes PRF in order to improve the healing of the soft tissue. Membranes. Membrane actually it's something that has been forced on us because we know that when we work with particulate grafts, we must use a membrane. Otherwise, we will have invagination of the soft tissue into the site and we are not going to have the volume that we are expecting to have. But actually, membrane, it's not just additional cost. It's not just additional time and skillfulness in order to work with it. As well, membrane prevent the periosteum from the osteoprogenerativity of the periosteum. We block the periosteum when we use a membrane. And of course, sometimes we deal with postoperative complication, and we know that exposure can lead to contamination, loss of soft tissue, loss of hard tissue. We live with that, like that's what we have. That definitely, if we can get rid of all of those, that will be fantastic. So due to the fact that of the complexity of the procedure, the time that it's consumed, and the cost, many clinicians prefer many times not to do socket grafting. And of course, not all the time the patient is willing to pay for all of this procedure. Therefore, we invented bond cements. Bond cements actually works completely different than traditional grafting. Instead of tension-free flap, we want to have the flap with tension. We stretch the flap. That's something that we never did in the past. Why we can stretch the flap? Because soft tissue healing normally starts by retraction. And if the soft tissue cannot proliferate above the membrane or above the graft, actually it will continue to retract. Therefore, we do the tension-free. Here, it's inverse. Due to the fact that it's based on biphasic calcium sulfate has the ability to let the soft tissue to proliferate above its surface. Therefore, we take the advantage and we can stretch the flap. We don't need a primary closure. We can leave it open, and that's something that you're going to see. You're going to see when we leave it minimally open and when we leave it more open and how we protect it. We don't need additive because the material transforms into the patient on bone. Of course, we don't use membrane because there is no need. Inverse, as soon as I will put a membrane, actually I need the tension-free and all of the rest. Here, we don't use membranes. And of course, due to the fact that calcium sulfate is a salt, is bacteriostatic, exposure never leads to contamination. The worst case scenario, if we didn't protect the graft, we lose some volume. Actually, more right to say, we didn't gain the right volume that we want, but we never encounter those infections that are related to exposure of the graft. So today I'm going to speak about the protocols for socket grafting. This is going to be my first webinar. My other webinar will be on lateral augmentation and then on sinus, etc. But now we will speak only about socket grafting, and we will speak about few protocols. One is without flap reflection. The other is with flap reflection. The other protocol, how we do socket grafting in the aesthetic zone, how we preserve the papilla, how we grow soft tissue instead of lowering soft tissue from another part, okay? And the last protocol is how we do when we place a simultaneous implant together with the augmentation. So now there are only 2 bone graft cements in the world, which are both manufactured by Augma, and this is the blue box, the 3D bond, and the red box. The blue box is a pure biphasic calcium sulfate and is intended to be used only for socket grafting from sphere central until second premolar or molar with a septum. Why? Because it's a short-term space maintainer. In bigger defect, you cannot use this type of graft. The other one is a composite graft, is the bond apatite, which can be used in all types of socket grafting, as well in lateral augmentation, sinus lift, and all of the other. But today, as I mentioned, we're going to be focused on socket grafting. Today, I'm not going to speak about the 3D bond, because we don't have enough time for that, but we will speak about the bond apatite, which is a composite graft. Bond apatite is a composite graft of 2/3 of biphasic calcium sulfate and 1/3 of HA in a particular particle size distribution, in a specific particle size distribution, and different shapes that this hydroxyapatite resorb as well. So in socket grafting, we have 2 options, as I mentioned. One is without flap reflection, and the other is with flap reflection. So we are going to start without flap reflection. When can we do it without flap reflection? Without flap reflection, we can do it when we have 4 bony walls, simple extraction. There is no need to raise a flap. So actually, we perform the extraction, and later on, we do the socket grafting. So this is the bond apatite. As you can see, it's come in the syringe, smart syringe that contain the saline and contain the powder. While you're advancing the shaft, the saline is mixed with the powder until you have the right viscosity. First thing that you need to do is to extract, to perform a complete debridement if needed, and just later on you activate the material because it's cement. You cannot activate the cement before you prepare the site. So prepare everything. While you're ready, then you can start. This is the bond apatite syringe. As you can see, it contains a shaft, 2 pistons, indicator line, a cap, and a tube. So first thing that we do, because it's a little bit hard to push the shaft until the liquid is mixed with the powder. So we recommend to place the shaft in the palm of our hand and start advancing it slowly in order to see that all of the saline from one compartment is going to the other compartment. It is very important because if you push the shaft fast, the first piston will reach the blue line, which indicate that now is ready more faster than the liquid the liquid has been mixed with the powder. So it's very important to push a little bit slowly, not too slow, but to push a little bit slowly. Then you start to see that the liquid is going from this compartment to this compartment. And then you continue to push until this first piston reaches the blue line. So let's see how it goes. We place the finger at the top of the syringe, and then we advance the shaft. Now, by twisting and pulling motion, we remove the cap. And in order to eject the material with control, we don't use it like a regular syringe. We don't use the thumb in this moment. We place the shaft in between the finger, the pointer and the middle finger. And then we grasp the handle of the syringe. Let's see how we do it in that way. And we approach to the site. Now we start ejecting the material into the site. Always slightly overfill. Now, if it's not enough, you're going to see that in the syringe, there is a little bit remnants. In order to eject the remnants of the syringe, we change position, and now we use the thumb. As I mentioned, slightly overfill. Immediately after, take a dry gauze, unfolded one, place above and press strongly with your finger. It's extremely important to press strongly with the finger. The material must be well compacted at the cervical zone. We don't need to take something and to push it into the apex. There is absolutely no need because it's not granules. Immediately after, and by the way, we press with our finger for 3 seconds, not more, but we press firmly. Then we take a periosteal elevator, which is a little bit more narrow than our finger, and we continue for additional few seconds to compact the material in the cervical zone. The material must be well compacted. Now, if the material will not be well compacted, the material might float after a few days, and then the patient might experience discomfort. So you can avoid it just by pressing properly with the finger for 3 seconds, and then with a periosteal elevator. Thereafter, we remove the gauze. And as you can see here, because we didn't reflect the flap, there is a gap. The material actually set in that time, but you cannot leave it exposed, because if you leave it exposed, actually it will start to wash out after 1 or 2 days. We must protect it. So how we do it? We take a collagen sponge or a collagen plug. If we take a plug, we need to squeeze it and then do the same what we are doing here with the sponge. Now, the collagen sponge should be collagen sponge that will not resorb less than 7 days. It should be there at least 7 days. So what we are doing, we need to anchor it to the soft tissue. So we go with our needle from one side to the other, and then to the other side. We place it on the exposed socket. By the way, during the time that we prepare the collagen sponge, what we are doing, we give a gauze to the patient and tell him to close his mouth until we prepare the collagen sponge. The collagen sponge or the plug, we hold it in our hand, we do the procedure, and then we take out the gauze from his mouth and actually continue. We ask our assistant to help us to hold it in place, and then we anchor it to the buccal and then to the lingual. We make our first knot, and then we do a cross suturing above. This is very important because if the collagen sponge will go out, the material is not protected and it might wash out. Now, one thing is very important. The collagen sponge, we don't try to undermine and to put it in between the soft tissue and the material. Inverse. We place it above, okay? Because we want to let the soft tissue to proliferate underneath. Soft tissue know how to proliferate fantastic on calcium sulfate. So actually, don't try to do it like with the membrane to undermine it between the soft tissue and the material. Inverse. It should be on top. Okay? And as you can see here, a cross suturing above in order that it will be stable. Here, by the way, in the animation, it's not the right way to do it, unfortunately, but you're going to see it on the clinical aspect. Let's see it on a patient. We extract the tooth. Clean the socket. And now we are ready to activate the material, as I showed before. until the first piston reached the blue line. We remove the cap. And now we eject the material into the socket. Again, don't try to push the material until the bottom of the socket. It's not important. There we have the blood clot. It will do the work for us. Now we take a dry gauze, press strongly, first with the finger, then with the periostal elevator. You don't see it here. And we remove excess. Now, all of this gap should be protected. Otherwise, the material will wash out. Therefore, we take a collagen sponge or plug. We perform a mattress suture in it. Place it above. Make our first knot and then a cross suturing above. Now, as you can see, we didn't undermine, we didn't reflect the lingual flap or something like that. And it's looked like that. Everything is on top. Don't even try to put it in between. Why? Because if you do it, actually you inhibit the healing until soft tissue will proliferate. So you just place it above. It does not look nice, but it's extremely effective. Now, there is questions of clinicians who ask me, can we use other barriers? The answer is yes, but actually you don't need, because this one do the work wonderfully. It's not expensive. You place it above, it resorbs exactly on time. You don't need to remove it. And the problem is that clinicians, when they use membrane, they're trying to undermine it, which is wrong. It's inhibit the healing, and they need to take it out. And if they will not take it out, the material might get contaminated. But otherwise, due to exposure, we didn't have even one case of contamination due to the bacteriostatic nature of calcium sulfate. Now let's see how it heals 7 days post-op. Here you can see the collagen sponge resorb already, and we have a gap here. This is not a reason to be worried, because it's going to proliferate. By the way, take a look at the color of the soft tissue and the interaction between the soft tissue and the material. It's beautiful. 3 months post-op. That's how it looks. By the way, this is a new bone. Don't expect it to look radio-opaque like other graft that you place there, because when you place other graft that integrate with the bone, actually what you see in the radiography is the graft himself. It's not a new bone. This is a young bone. And when you drill inside, it's type 2, type 3 bone. That's how it looks in the CBCT. And here you can see the beautiful soft tissue healing. Everything is a beautiful keratinized gingiva that actually close the gap by itself. And when we open for implant placement, you can see the quality of bone that we have here. Here and there, you can see small particles of the HA. Those belong to the big particles of the composite graft. As I mentioned, it's in a different particle size distribution. In this stage, the small and medium-sized particles resorb completely. However, the bigger part, which are less than 10%, are still there, but they look like bubbles because they are in a process of resorption. So don't get worried about it. Just leave it like that, and it's going to resorb. Later on, I will show some histology and what's happened. But this is vital bone. Now when we drill, it's type 2, type 3 bone after 3 months. There is another option, wonderful one. We loved it. It's called the Aurade One Dressing. Unfortunately, in the US, we still don't have it. But in Europe, they have it. And we work with it and we just love it. So how does it work? As you can see here, we have a gap. So we place the Aurade, which adhere to the soft tissue. But because we want it to be left there for a longer period, so we must secure it by suture. So we go in mattress suture, horizontal mattress from one side to the other to the other side again, and a cross suturing, and that will keep it in place until it will resolve. Normally it resolves about 10 days, something like that, but we must secure it, otherwise it will fail. And I want to show you the technique. And by the way, this is the outcome. Okay, you can see soft tissue healed and the bone is there. Now let's see how it works, how we do it. We extract the tooth. And now we take the aluminum from our scalpel, or we can take any other template, and we trim it according to our needs. By the way, it's a very good product. We love it very much. And you see, we trim it, and thereafter, we cut the Aurade accordingly. Now we eject the material into the site, take a dry gauze, press strongly with the finger. Thereafter, take a periosteal elevator and continue to compact only in the cervical area. We don't need to push it into the bottom of the socket. If we need, we can add, always slightly overfill. Again, take a dry gauze, periosteal elevator, compact it. That's the way how it should be done. Remove access. And now protect the gap. We take the Aurade. As you can see, it's adhered to the soft tissue. It's adhesive, so we place it. But we must secure it, otherwise it will fall after a few hours. So we make our suture from one side to the other. Normally we use suture that can last at least 3-4 weeks, something like that. Never use a chrome gut suture. And you can see we leave it like that. The Aurade is going to completely resolve. It's extremely biocompatible, so it's worked very nicely. There is no risk of contamination, and it's a very efficient way to protect the graft. So what are the small things that makes the difference when we're working with bone cement? By the way, we need to remember that bone cement works completely different than traditional grafting. So socket debridement should be prior to cement activation. That's very important. Now, after extraction, wait until you see some blood. Don't place the material if the socket is dry, because you don't want to end up with dry socket or something like that. So wait until you see some blood there. Now you can activate the bond appetite and inject it into the site. Place a dry gauze, press strongly with the finger for 3 seconds. Then with a periosteal elevator, because the material should be well compacted. It's extremely important. Material that will not be compacted at the cervical area, probably the patient might encounter discomfort 3-4 days later. So you can avoid it. Now, you must protect the exposed graft. Normally, calcium sulfate, the bond appetite can be left exposed about 3 millimeters, nothing will happen. But when it's more, especially in the socket, you must protect it with a collagen sponge, collagen plug that should last there at least 7 days. Do not use gelatin and do not use PRF just because they resorb too fast. They have absolutely no effect on protection. As I mentioned earlier, if you want, you can use other barriers, as we show with the Aurade, which is amazing. We love it. Okay? Or you can use also membrane, but there is no need. It's cost more. Of course, you can make a mistake and try to undermine between the soft tissue and this is mistake. You need to place it above. The edge of the membrane might irritate the patient and he's going to play with the tongue. So I don't recommend. I do recommend to use it as we show it here, okay? And do not use chromic gut sutures or any suture that might resorb too fast. The other option is when we do flap reflection. Now, when we need to do flap reflection, normally is when I don't have a buccal plate or I have a big defect and I need to see and to clean the area. But also here, due to the protocol, they are so simple that I think that many general practitioners can do it. They don't need a huge knowledge or experience with surgery, because what we are doing here, we perform a minimal flap reflection. And how we do it? We do a mid-crestal incision, and we do just one vertical incision that should not exceed the mucogingival line junction by more than 3 millimeters. That's all. Okay? Thereafter, we do intrasulcular incision here until the middle of the distal tooth. Now, we undermine with the periostal elevator, and we go 3 millimeters into the mobile mucosa. However, where is the defect himself? We go as much as needed. If there is 8 millimeters, 9 millimeters, we go as much as needed. And then we take our periostal elevator with 45 degrees angle and go to the distal. In that way, 3 millimeters, 3 millimeters, 3 millimeters. We must expose the entire defect in order to see and to clean. After that, immediately, we stretch the flap. As you can see here, we take the mesial corner and stretch. 3 millimeters into the mobile mucosa will enable us to stretch at least 6 millimeters. Okay? Now, if in the distal area, we cannot stretch enough, what we are doing, we take the periostal elevator and we undermine 1 more millimeter in 45 degrees angle to that direction. And then you're going to stretch and you see that everything can be closed, no matter how big is the socket. We reflect the flap. And now we prepare, when everything is ready and we perform the complete debridement, we activate the bond appetite syringe. As I mentioned, put the shaft in the palm of the hand, the finger on the cap, start advancing the shaft slowly, see that the liquid is going from one compartment to the other until the first piston reach the blue line. Now the material is ready. Remove the cap, place the shaft between the pointer and the middle finger, hold it like that, and start ejecting the material. When you eject the material, in this case, when you don't have a buccal plate, eject it buccally and occlusally. Immediately after, don't wait. After that you finished, here you can see that you can add a little bit more if you need. Take a dry gauze immediately after, place above, you see it's unfolded gauze, and press strongly buccally or firmly buccally and occlusally. First with the finger for 3 seconds, and then take a periostal elevator and continue to compact for additional few seconds. Material that is not compacted will not give you the same results. remove the gauze, and then grasp the mesial corner of the flap immediately, stretch and suture. Then the distal part, stretch and suture, and then the middle, and then in between if needed, and finally the vertical incision. As you can see here, we don't do any periostal releasing incision, absolutely not. We just stretch the flap. That's something that we never did before, okay? Here we can see it on a patient. We extract the tooth. And now we evaluate the defect. We see that we don't have a buccal plate. Now we distinguish between the mobile and the keratinized tissue. And in 45 degrees angle, you can see, we're going beyond the mucogingival junction by 3 millimeters, not more. Then we reflect the flap to see the entire defect. And immediately after, we stretch. You can see how much we can stretch. That's completely perfect. We activate the bond appetite. Eject the material into the site, into the socket. After ejecting the material, immediately place a gauze. Don't wait, because you want that the setting will take place. First, press with the finger, then a periostal elevator, remove excess, and now stretch and close. The closure should be mesial distal middle or inverse distal mesial middle, and in between. It's very important, otherwise it will never get closed. So we start here with the mesial, then the distal, then in between, then in the middle, and then in between if needed. And here you can see how the tissue is stretched, okay? You're going to see that in a few days, the vestibule is going to be exactly in the right place because there is adaptation of the area, but you can see that when we move the muscle, the suture do not move because the muscle is not engaged. See? And if we have 3 millimeters of graft exposure, it's completely fine. Soft tissue going to proliferate and bridge the gap, but not more. If it's more, then you need to add a collagen sponge and to protect it. But I'm going to assure you, once you get experience with that, almost each one of your cases can be closed in that way, and there is no need for collagen sponge. But if it happens, especially at the beginning, and you're not sure if you can close, place in addition collagen sponge. But normally, there is no need. That's how it looks at the day of graft placement. By the way, I wanted to show you here. You see, the bottom of the socket is not filled with the material. It's completely fine. The blood clot will do the work for you. That's how it looks 7-day post-op, 12-day post-op. Now, 3 months post-op, that's how it looks in the CBCT, young bone that was formed there. This is a soft tissue appearance, and I want you to see the quality of the bone that we have. This is a real vital bone. We are talking here about regeneration and not integration. Here and there, we still see the big particles of the HA, but they are in the process of resorption. And this is the quality of bone. It's a real vital bone. When we drill, after 3 months, it's type 2, type 3 bone. We can see it here as well. Remember, small vertical cut, 3 millimeters beyond the mucogingival line, okay? Reflect the flap, see the entire, you see here, we do intracircular, go undermine with the periostal elevator, then with 45 degrees angle into the distal area, immediately after stretch to feel the ability to stretch the soft tissue. Never do a periostal releasing incision. See, it's stretched. That's how it looks before, and here you see beautiful healing of the buccal plate and the bone missing that was there. Also, when we have multiple teeth, it's the same technique. Here you can see if it's 3 millimeters of exposure, don't worry. 3 months post-op, everything is closed and breached. And that's how it looks at the re-entry. This is the patient on bone. Now we need to remember, because we are not talking about integration, we're talking about regeneration and resorption and complete transformation of the material into the patient on bone, the radiographic appearance is completely different than what we are used, because first day, it's radiopaque. 2-4 weeks, everything disappeared. This is the osteoid before calcification. Don't worry. 12 weeks post-op, then you start to see the bone is formed again, but again, it's a young bone. Okay? So don't expect it to be radiopaque like a bone that was there for 40 years. It's a young bone. When you open, you're going to be surprised the quality of the bone. But in order to have a good quality of the bone, don't forget to compact the material at the cervical area. It's very important. Now, is it bone? In the radiography, we don't know exactly what it is. We should take a core for histology. So what we did here, you can see it's a big defect. We place the bone apatite. 3 months later, when we open, we see it's nice bleeding bone, but we still are not convinced that it's bone. Of course, we are convinced, but I'm just saying it. And here you can see it in the CBCT. We took a core for histology, and you can see that after 3 months, the sample consists mainly on vital new bone with osteocyte, which shows you that this is vital bone. Otherwise, it's a sterile sequestrum that are integrated with the bone. This is bone. And vascular structure. The area of residual scaffold were surrounded by connective tissue and occupied only 10% of the sample area. By the way, normally when we talk about other graft, we are expecting to have integration. Otherwise, we don't have a functional continuity to load the area. Here, it's well completely different. Here, what happened is, already after 3 months in sockets, the small and medium-sized particles resorb completely. The bigger particles, okay, first are surrounded by connective tissue, they resorb, and the connective tissue goes through ossification and turn into the patient on bone. By the way, it's happened the same with the small particle and medium-sized, but already in this stage, after 3 months, you don't see them and you don't see any remnants of them. You just see 10% and 90% now it's a vital bone of the patient himself. Now, what happened after a longer period? Of course, we have many cases like this, but I want to show you one of them. Another case, okay, we took a core for histology, and by the way, I want to show you something, which is very interesting. What we see here is rebuilding of the cortical plate. Normally, with grafts that do integration are occupied 80% of the graft or 70% of the graft, you never see the cortical plate is built again, unless you have at least 60% vital bone. Here, you can see that after 8 months, the cortical plate is formed again. Exactly like when we do extraction, we just leave the blood clot there to do the work, and then we see the cortical plate. So that shows us that it's real bone. But it's not enough. So we took histology. And as you can see here, you remember the big particle that was there? Here we have just 3% of the scaffold. Everything turned into the patient on bone, which is wonderful for us. We are talking about real regeneration. Now, there are many who ask me what happened in the long term. Logically, the rationale, if it's bone, it should behave like bone. If the bone should resorb, it will resorb. If the bone should stay, it should stay. but we wanted to show you what's happened here. So in this case, we extract the tooth, we place the bone appetite, and after 3 months, we see the young bone that we have here. You see, it's a little bit radiolucent because it's a young bone. At this stage, we place the implant, and after 6 months, we see the maturation of the bone. It looks much more mature than here. And that's the soft tissue appearance after 4 years, okay? It looks wonderful, it's very stable. And here, it's after 6 months, okay? Take a look what we see here. And take a look what we see here after 4 years. Beautiful maturation. There is a continuation of remodeling of the bone and the maturation of the bone because this is bone. It's not something else. Now I want to talk about the aesthetic zone. The aesthetic zone, it's a different. Why? Here, actually, I'm showing 2 cases that are much more than only socket. But I consider them as a socket just because we did the extraction in this time. And we did augmentation simultaneously. But actually, it's not a socket, it's much more than a socket. Here, we need to preserve the papilla. Here, it's a young guy with a high smile line. Here, we have another problem. It's a very thin type of soft tissue. And we know when we work with a thin type, every small mistake, we're going to pay for it. We're going to have resorption. Unless we grow soft tissue. We don't borrow from other place. Because if we borrow from other place, then we need to correct the papilla. Here, we don't do it. And I'm going to show what I mean by that. So we have a big defect here. We need to extract the tooth. By the way, I want to thank Dr. Baranes for many of his cases here. And I'm showing them. Some of them we did together. So here we need to extract the tooth. As you can see here, we distinguish between the keratinized and the mobile mucosa. We do our vertical cut, and by the way, only one vertical cut because we don't need a tension-free flap. We have a stretch flap. So one vertical cut, if we do, is enough. Sometimes we do it by envelope, but personally, I don't care to do one vertical cut because it's not invasive. I'm not going too up into the mobile mucosa. So by the way, you're going to see that when you do in that way, your patient will come with almost zero swelling, zero pain, because we are not going up into the mobile mucosa, especially if we give them a dexamethasone according to the protocol. So what we're doing here, 3 millimeter into the mobile, and then we start to undermine with the periostal elevator, and we clean the defect. Now, in order to preserve the papilla, we need to evaluate the defect, okay? Here we see that we have bony wall that can preserve the papilla for us, and then we can grow soft tissue here in the area. I'm going to show how we do it. So we activate the bone appetite, then we inject it into the site, buccally and occlusally, take a dry gauze press, then a periostal elevator, and now we don't close the flap. What do I mean by that? I mean, we suture in one end, in the other end, and in the middle, as you can see here. Why? Because we want to grow soft tissue in this area. We don't want to stretch and to close it because we want to preserve the papilla. But again, the material cannot be left exposed. We must protect it. So, as you remember, we take a collagen sponge or collagen plug. If you use a plug, just squeeze it. You can use as well the Aurade wherever you have it. And we secure it here when we work with the collagen sponge into the buccal aspect, palatal, and then across suturing. Remember, don't try to undermine the sponge underneath the flap. Inverse, it should be placed above. It doesn't look nice, but it's extremely efficient. And of course, we cannot use a flipper. We need to use a temporary Maryland, and to bond it, to the other teeth. And now, at the day of the surgery, you can see that the papilla is perfectly in place. 2 weeks later, the papilla is still perfectly in place because, don't forget, we grow soft tissue. We don't borrow it from other place. Normally, of course, you don't need to take the Maryland bridge out in order to see what happened. We did it in order just to show you what happened underneath. So here already it was bridged, but still it's very, very young soft tissue. 4 weeks later, see the papilla is perfectly in place. And here already is bridged. We never get scared that it's going to be infected due to exposure. We never encounter even one case of exposure that lead to infection. Yes, it can be infected if you put it in infected sinus. It can be affected from if you put a membrane that stay a longer time and it's absorbed a lot. But exposure, never. We never had even one case of infection. That's how it looks 12 weeks post-op. You can see beautiful papilla in place and beautiful keratinized tissue that grows there, that proliferate above the exposed area. And now, of course, we need to see if we have bone. So that's the bone that we gain. You remember how it was. And everything is bone. And of course, now we can place the implant in the right position and continue with our procedure. And this case, it's a thin type. Again, it's the same protocol because when we don't borrow soft tissue, we grow soft tissue, we don't have the resorption that is expected. But we need to know, if we wouldn't have bone here, definitely papilla cannot be here. But when we have bone, that's absolutely not a problem. So one vertical cut, we did it in the distal in order not to influence the anterior part. It's a huge defect here. Okay, we reflect the flap, place the bone appetite, compact it, and as you can see, we don't close. When we want to preserve papilla, we don't close the flap. We leave it open and we protect it. Here we protect it with a collagen sponge that placed above. And that's how it looks at the day of surgery. Again, never use a flipper. This is a Maryland. This is how it looks at the day of surgery. The papilla is here and here. That's how it looks 12 weeks post-op. 0 loss of papilla because we grow soft tissue instead of borrowing. Finally, I would like to speak when are the cases that we do simultaneous implant placement and how we do it. Of course, in the former cases, I wouldn't place an implant simultaneously because first, it's in the anterior zone and there was absolutely no bone. It was very difficult to stabilize an implant, so I don't want to take a risk. I prefer to do the augmentation, to gain the bone, and just later on to place my implant because it's only 3 months later on. But in the other cases, when we do a full arch or we can place our implant and be sure that it's going to be stabilized, definitely we can do it. So what we are doing here, this is a case of Dr. Amos Yahav. I want to thank him for this. We extract the tooth, okay? Placing the implant 1 millimeter below the crest level. And now when you work with cement, it's not granules. You don't need to push it in between the bony walls and the implant. You just eject it on the top, press strongly for 3 seconds, then with a periostal elevator on a gauze, and immediately stretch back and close the flap. Never use a membrane, never try to dissect the periosteum in order to close because you just stretch it. And of course, don't try to push the material this. So actually, if you do a full mouth like this, it's going to take you about 2 syringes, maximum 3, not more. Because you eject it on the top, and by the way, you eject it on the top here, and you eject it on the top here, on the buccal aspect, because you want to gain more bone, and you close. And that's how it looked. 3 months later, you're going to see that the bone even grows on the top of the implant. So that's how it looks at the day of the surgery. And here you can see the bone that was grown. You have a beautiful crest. By the way, there is a very nice presentation of Dr. Stefan Berg. I really recommend you to see it. Dr. Stefan Berg is a bone cement expert with a lot of experience. I enjoy to see his cases, and he shared with us, and wonderful cases. I really recommend you to see his presentation. Here again, you see when we have exposed threads, But when we have exposed threads, remember, first, the implant should be well stabilized in the bone. Again, place the implant below the crest level, and there is a big difference between threads that are within the bony envelope and threads that are out of the bony envelope, because those are much more predictable case. Those are out of the bony envelope, okay? You might end up with one thread or two threads exposed if you don't have a perfect stability of the soft tissue due to the movement of the soft tissue, okay? So that's how we started, and that's how we hand with it. So, Amit, can you take control, please?
Yes, thank you, Dr. Yahav, for a brilliant presentation. We will now proceed to the Q&A session, but before that, I'd like to make a few quick announcements. Our next webinar is scheduled for this coming Monday and will be given by Dr. Stefan Berg from France, focusing on full mouth ridge reconstruction. More webinars by different speakers are scheduled for the coming weeks and be shared with you via email following this session. Second, for those who would like to watch the webinar once more, we will send out a link to view the webinar in the email following today's session. Third, we also welcome you to take our free online course. As you can see on your screens, it's available for both mobile and desktop. You may access it through the link or the QR code using your smartphone camera. And lastly, at the end of the session, after you leave the meeting, you will be automatically redirected to complete an anonymous feedback form. Your feedback helps us to create new webinars that focus on your interests and provide you with valuable knowledge. So please take a moment of your time to complete this 1-minute survey and let us know what you think. And now let's move back to the Q&A. Dr. Yahav, our first question is, which brand of collagen plug do you use? HeliPlug and gel foam are back ordered and you cannot order them at the moment.
So in the US, we use, can you hear me by the way, Amit?
Yes, we hear you well.
Okay. In the US, we use the Matrix Derm collagen plug, okay? We saw that it worked very nicely. In Europe, we use the Aurade, which is amazing. And actually, we use as well the Jason of Botis, and there is also Zimmer is selling a collagen sponge. I don't remember exactly the name, so please forgive me for that.
Does the Aurade can replace the collagen sponge in all cases?
In most of the cases, yes. What we do sometimes in the anterior zone, in the aesthetic zone, we place first the collagen sponge, and on top we place the Aurade. That's something that we do. On the posterior, always Aurade you can use, because in the anterior zone, sometimes we don't want to have any pressure directly on the papilla. So then what we are doing, we're placing the collagen sponge. You can leave it like that, or to add the Aurade, because we saw that there is a very nice healing with the Aurade.
Why you don't want using PRF and membranes with calcium sulfate?
First, there is no need, because normally we use the PRF in order to improve the soft tissue healing. We have a wonderful soft tissue healing above calcium sulfate, because actually the calcium sulfate provides a wonderful matrix for soft tissue to grow above it. So everything that you put in between actually impairs the healing instead of improving the healing. When we work with traditional grafting, definitely PRF are helping. But here, no, there is no need. The second, on exposed socket, definitely I don't use the PRF to protect the socket, because in 2 days it's resorbed. So it does not have any effect. Or the Gelatape, we never use it. We need to put something. Now, we don't use as well membranes, just because when you place a membrane, you impair the healing, you block the periosteum, then you need a tension-free and all of the other stuff. It doesn't say that it's not going to work, but it's much more complicated and there is no need. You're going back to the traditional grafting. We don't need it. So we take advantage of the biphasic calcium sulfate, and we don't need to go back to traditional grafting.
Some people have no blood even with corretting or drilling. What do you recommend?
Can you repeat?
Some people have no blood when drilling. What do you recommend?
First, to wait until you see blood. No blood, no healing.
Is there a risk for development of granulation tissue after using Augma bone material?
You mean on the top? You don't going to see invagination of the soft tissue unless actually the material is not well compacted on the top. So actually, if it's not well compacted, it will start floating. And after a few days, actually, soft tissue might invaginate inside. But it doesn't say that the material stay hard for those days. But if it's well compacted, soft tissue will proliferate and breach the gap. Normally, it does not happen that we have invagination of soft tissue, unless we really did it poorly by pressing.
Okay, a few more questions. If you could not obtain primary closure in the buccal plate defect cases, could you use collagen membrane like in the previous cases you shown?
Collagen sponge, not collagen membrane. Do not use membrane in those cases. There is no need for that. Use a collagen sponge because the only thing that you need is a protection. By the way, collagen sponge for exposed, normally if you don't need a primary closure, but it's sufficient that you will have maximal closure, which means that 3 millimeter of graft exposure is completely fine. You don't need to protect it. Otherwise, in sockets and only in sockets or defect when they have at least 2 bony walls, if more than 3 millimeter is exposed, okay, take a collagen sponge or take the Aurade and protect it, okay? Otherwise, the material will wash out. You will never encounter contamination or inflammation or infection due to exposure, but you lose volume. So you must protect it with a collagen sponge, and the collagen sponge should be secured by suture, as I show it here.
To clarify, what flap is needed, partial or full thickness flap?
Full thickness flap. Full thickness flap, because always when you do a augmentation, you need to come in direct contact with the bone. So you make a full thickness flap. But again, as you can see, it's a minimal flap. With those flaps, the patient normally come with no swelling, no pain, because it's minimal. We are not going deep into the mobile mucosa.
What type of sutures does Dr. Yahav use or recommend?
Actually, you can use almost any type of suture as long as it's not chrome gut or other suture that resolve in less than 2 weeks. Okay, so you can use polytetrafluoroethylene suture, you can use polylactic acid suture, you can use monofilament or this. There are those who use as well silk suture and works very nicely because they are not afraid from contamination. So any suture that you like. Of course, if you use a suture that resolve by themselves, you don't need to remove them. If you use sutures that stays, you need to remove them after 10, 12 days. But again, do not use chrome gut for those situations. And by the way, nylon as well, it's wonderful. I know many clinicians who use it. So.
Even though the presentation is about socket preservation, can the material be used for grafting for period defects around teeth or implants?
Yes, definitely yes. Definitely yes. I believe that in one of our next presentation, we're going to show something about it, but definitely yes. When you work in period defects, the most important is scaling root planning, okay? And then ejecting the material into the site. Again, the same flap, one vertical incision, no more. You reflect the flap, don't go more than 3 millimeter into the mobile unless where the defect is. Eject the material inside, press strongly and stretch back for closure. Make sure that the tooth is not mobile. And of course, sometimes what you need to do is selective grinding, because sometimes when you work on period teeth, there is an overeruption that comes a day later, and it might exert pain to the patient. So sometimes we deliberately do a minimal selective grinding on the tooth after augmentation.
We have a few more questions that were added. What does your protocol for dexamethasone for your patient? Do you always prescribe it for all bone graft cases provided medical condition allows it?
Mm-hmm. Again, the protocol, due to the fact that the protocol is a short-term for a steroid, okay, for dexamethasone. So actually what we do in the first day of the surgery at the morning, not the day before, because otherwise he will not sleep at the night, we give him 3 pills of 2 milligram dexamethasone. The day after, 2 pills of 2 milligram. The day after, together, by the way, not separated, together. 3 pills in the day, in the first day. The second day, 2 pills of dexamethasone. The third day, 1 pill of dexamethasone. Normally, it's enough. Many of those cases even don't need it because the surgery is not invasive by its nature. But if you want to be completely on the safe side, that the patient come and say, I didn't feel nothing, we give it.
What do you think about horizontal augmentation in knife-edge bone defects?
That's something that's going to be in one of my upcoming presentations, so keep follow us. I'm going to give a presentation about lateral augmentation, all the challenges, how we can be sure to have the best results, and how we can prevent ourselves from failures or something like that.
Have you had experience with using this material in sinus lifting procedures?
Of course, we do it, and we will have a webinar also in this.
Okay, I think the last question.
By the way, for sinus is a different protocol, a different protocol of activation and working with it. So just wait for this protocol, and definitely we're going to give a webinar on this. I think also Stefan Berg can show beautiful cases of sinus that he did. I'm just eager to see his presentation, and definitely can share it with our audience.
Sometimes the material breaks when compacting. How to finish and what to do?
Nothing happened. If it's break, for example, if you place the material, okay? At the beginning it's set. If you press immediately, it's set. But it's not hard like a stone. Now suppose that you work with the suture and you break it. Nothing happened. Take a dry gauze, press for 1 second and continue to suture. Nothing happened. Absolutely. Because I know that sometimes the clinicians are not used to that, get scared. Oh, now it's break. What should I do? Nothing. Just press for 1 second and continue to suture. Absolutely. By the way, it's extremely forgivable material. You are not going to encounter the post-operative complication that we are used to see with traditional grafting. Yes, if you don't know how to work with the material, you don't compact it well, maybe you will not find the bone that you expect. You will find some mushy layer there because you must compact it. Exposure will never lead to contamination. Never. I never encountered in such case because the material is a salt.
We have a few more questions now. What is the histology difference between Augma bone formation and classic Holographed formation?
Big difference. By the way, Holographed do a perfect integration. When you take a core for histology with Holographed, you will see a beautiful integration between the particles of the Holographed, but you will never see osteocyte within those particles, which shows that you have a sterile sequestrum that are integrated with the new vital bone. Does it work? Yes. Does it work good? Yes. Is it integration? No. Is it regeneration? No. And by the way, it depends if you use the mineralized or demineralized, it works differently.
Very nice presentation. Any statistics, any reason for failure?
First, you might have failure if you don't work according to the protocols. Most of the failure that we saw is because clinicians didn't want to change their habit. They tried to work with bone cement exactly like they used to work with traditional grafting, with the tension-free flap and all of those stuff. Then they might end up with losing of volume. They might end up with losing of the material. They might end up with dislodgement of the membrane and all of the stuff that are related to traditional grafting. The most important thing is when you move from traditional grafting to bone cement it's a shift in your mind. You need to understand it's worked differently. So you cannot apply, no matter if you work 20 years, 30 years, and you are big expert, don't bring your habits from traditional grafting and try to imply them in bone cement. It's worked differently. It took us hundreds of cases to learn those protocols, because don't forget, when you invent something, first you work like everybody. Later on, you start to learn exactly how this material is working. The benefits of this material, that we can work with stretch flap. That's something that we never did. We can work without membrane. That's something that we never did, okay? The procedure, the graft placement and stabilization is in a minute. You don't need more than this. So you need to change all of your state of mind in order to know how to work with this material. It's not difficult, but just get rid of the old habits when you work with the new material. That's very, very important.
Few more questions. Can we use Augma bone material mixed with autogenous bone particle to improve result?
No need, because we are not talking about integration. As you saw here, the material transformed by himself into the patient on bone. So mostly there is absolutely no need to draw blood from the patient, to take autogenous bone graft. The material turned completely in 3 months into the patient on bone. By the way, in lateral augmentation, it's take a little bit longer because we have less bony wall to support it and less cells. So it's take a little bit longer, but no need. You're going to see when you're going to drill, you are drilling into bone. So absolutely no need. You want, you can mix, but there is absolutely no need.
Similar question, can I mix other graft with this one, FDBA?
Again, no need, because this composite graft that do, you know, when we started, we started with the pure biphasic calcium sulfate, which is the 3D bond, the blue box. At that time, we didn't have the composite graft. So then some clinicians mixed. Why they mix? Because they wanted to create a composite graft to slow down the overall resorption. So definitely they can use the 3D bond, make their own cocktail with Holographed, with Xenograft, with other synthetic in a ratio of 2:1. But you don't need, because everything is ready for you. And not just that it's ready for you, it's come in a smart syringe that the liquid, when you press, make you exactly the right viscosity for the cement that you need. So absolutely there is no need. Unless you like to make your own cocktail, you can go to YouTube and see how we do it with the old version. But absolutely you don't need it.
Can we use Augma for vertical augmentation?
Actually, for vertical augmentation, we still don't have a protocol that I can tell you, if you do what I'm showing you, 95% of success you're going to have. We don't have it yet. We're thinking about different protocol, because we can copy the others, what they do, but still it's complicated and it's not predictable. So unfortunately, I cannot tell you what is the protocol for vertical. Even so, I have some nice cases that I can make a show off of them. But again, it's not predictable, and we still don't have the protocol for this. So we recommend you don't do vertical in this stage with the bond appetite, because the material might be very elusive. When you place it, it looks exactly like you place it, but it's not going to stay. So don't do vertical in this stage.
How long is your follow-up on this product? I believe they mean the material. How long do you usually wait?
The material is actually from 2013. From 2013. When we started, we have only few doctors. Now, thanks God, we have dozens of thousands of doctors around the world that already working with this. So we have a lot of experience with this. And again, when it's turning to bone, it's the patient on bone. It's not something else, because we used to think about other particulate that integrate with the bone. When there is particulate that integrate in the bone, indeed, what happened? What will be with this connection between those particles and the bone in the long run? And by the way, there are good products that integrate very nicely with the bone. Here, no, you don't have any product. It's the patient on bone, and it's going to behave like bone. I show you the case, what's happened after a few years. It's just the turnover of the bone continue and the remodeling of the bone continue. The same. So this is bone.
And our last questions, as I see it at the moment, how long does the suture need to last?
Normally 12 days, 2 weeks, not more than this.
Okay, I hope I haven't missed anyone. Thank you once more, Dr. Yahav, and thank you all for joining us. At this time, we will conclude our webinar. We look forward to seeing you on Monday. Goodbye for now.
Thank you very much all. Looking forward to see you in our next presentations. Thank you very much.